Hello, my name is Ashley Potapchuk-Tucker, and this is my presentation on the efficacy of iStat troponin testing in emergency departments. Troponin, what is it? Troponin is a protein. It's found in striated muscle, especially the muscle in the myocardium. When these highly sensitive enzymes break down and they go into the bloodstream, we use it to tell us if some kind of damage has been done to the heart. It's usually pretty specific to the heart, but it can signify a myocardial infarction or, heart failure, things like that. It is a cardiac biomarker which has increased diagnostic accuracy in patients with acute chest pain in comparison with conventional biomarkers. So when we see this, when we draw it, we know that something's going on with the heart. We just need to figure out what. The presence of elevated cardiac troponin can signal to an emergency provider, in conjunction with other symptoms and ECG results, that there is some type of damage to the heart and that it's happening in the heart, like I said. When combined with symptoms such as acute chest pain, shortness of breath, diaphoresis, and or an abnormal ECG, the cardiac troponin is considered the gold standard biomarker for detection of myocardial infarction, MI. The detection of elevated troponin is a vital step in the diagnosis of acute MI. The faster elevated troponin can be detected, the faster a patient having an acute cardiac event can receive proper care and morbidity and mortality can be reduced. So who requires that a troponin test be performed, and where should we do it? Patients who present to the emergency departments with chest pain, shortness of breath, or left arm or shoulder pain are typically given an EKG. An EKG is performed to determine if there's any acute damage happening to the patient's heart. However, a patient could have a cardiac damage that does not present on EKG. It is the job of the emergency department provider to interpret the EKG and determine if a patient is having an NSTEMI versus a STEMI. So a STEMI is a ST segment elevation myocardial infarction. If you look on the right-hand side, you can see the differences. On an EKG, you'll see some ST elevations. That'll signify that there's some kind of acute cardiac incident that's happening. It also signifies there's some kind of blockage in the heart, depending on which part of the EKG you see it on, lead 3, lead 4, etc., etc. These are acute. Patients need to go to a cath lab or OR immediately to clear that blockage. However, an NSTEMI, which is a non-ST segment elevation, does not always exhibit an abnormality such as ST elevations on an EKG. So STEMIs, like I said, they present with EKGs. They're easily defined. So sometimes this lack of anomaly can make providers think that the patient is okay, or maybe they're just having unstable angina, or they're having GERD, or maybe a panic attack. So it can kind of make a false sense of security. That's why we order troponins to go in conjunction with an EKG to make sure that if somebody's having an NSTEMI, which isn't evident that there's any cardiac issue or damage happening to the heart, the troponin will let us know definitively if there is. So with that being said, let's go over the need for iStat or point-of-care troponin testing. So detection of MI requires rapid triage and intervention. MI falls under a category of acute coronary syndromes, or ACS. ACS includes unstable angina, non-ST segment elevation, cardiac myocardial infarction, and STEMI, like we just spoke about, or STEMIs. The rapid identification of elevated troponin is not only clinically necessary to rule out things like unstable angina or NSTEMI, but also vital since ACS requires immediate hospital admission and the prognosis is directly associated with timely initiation of revascularization, or like PCI, going into the cath lab. Misdiagnosed or late diagnoses may have unfavorable clinical implications. Patients could get worse or potentially, pass. Troponin tests should be resolved quickly during a cardiac event because rapid turnaround times directly reduce the time to critical life-saving medical interventions such as PCI or cardiac surgery. When the patient experiences a potential heart attack, every passing minute leads to irreversible muscle death. Time equals muscle, and we work to preserve that muscle. Additionally, the more time that passes, and the more likely a patient will decompensate and have worsening symptoms, or worst case, the patient suffers a cardiac arrest. Working in a limited access rural ER, I can't tell you how many times this happened to me. We are waiting for the troponins, or we're waiting for to take somebody somewhere else, to the cath lab, to another hospital, and unfortunately a coup before they go. Fast results allow emergency departments to immediately identify if a patient's having an MI and trigger the STEMI alert system. The system activates the cardiac interventionalists, the cath lab nurses and staff, and also puts into motion certain medications that can improve outcomes like aspirin or nitroglycerin. Troponin in emergency settings should be stat. However, blood samples taken are then forwarded to a hospital's central laboratory, and results can take a lengthy amount of time. iStat is a handheld point-of-care system that requires only a few drops of blood and can provide troponin results in as little as 10 minutes. When compared to 30 minutes to 1 hour for traditional testing, and considering the time is muscle, the rapid result is tremendously beneficial. The testing can be done directly by emergency department staff without the hassle of having to use the tube system to send this to a central processing lab and wait the processing. And to the right, that's your iStat machine. You take whole blood, you take the little dropper there, the pipette rather, you put it right on the center part of that little iStat cartridge, you load it up into the machine, and you get the results right on that machine there. Although iStat troponin is proven to be valid and comparable to traditional whole blood testing, it should be used in conjunction with standard troponin testing. So yes, we might get a result from the troponin, the iStat troponin. We're still sending a whole blood to the a green top typically to the laboratory to give final confirmation. Decreased time can provide a nearly definitive diagnosis in conjunction with ECG and allow patients to be sent to appropriate treatment area, improving outcomes. So let's talk about the efficacy of the iStat troponin test. Although iStat troponin can reduce time for diagnosis, treatment for ACS, and can improve ACS outcomes, we must ask about the efficacy and cost effectiveness of the machine itself. Acute MI is one of the leading causes of death in the developed world. The prevalence of this disease approaches 3 million people worldwide, with more than 1 million deaths in the United States annually. So a lot of people have visits to the ER because of MI and MI. So delayed troponin times and diagnosis, the consequences. So studies have identified laboratory turnaround time, or TAT, as a barrier to patient process times and lengths of stay. These prolonged laboratory results may result in delayed recognition of critically ill patients and the initiation of appropriate therapies. There was a study that I read from 2010, it was the most recent one I could find, that determined the mean turnaround time for troponins, and the mean average in a busy ER was 69 to 149 minutes. So we're talking in between of that, maybe about a little over 90 minutes for the definitive troponin to come back. Now, that doesn't mean that we're going to wait around for somebody that has, ST segment elevations on their EKG before we send them somewhere. But for someone with an NSTEMI that's not presenting on EKG, and we're kind of just waiting for this result to come back, and we're waiting, and this patient decompensates in the meantime, that's a problem. And like I said, it needs to be reduced. The complications of having an MI, we see them on the side over there. These are all the things that can happen after an MI, but if we can get to a patient sooner and get them to the cath lab and open up that heart, open up those arteries, we can prevent a lot of this stuff from happening on the right. So patients presenting 12 hours after symptom onset show significantly higher heart failure hospitalization rates. 1 year death or heart failure hospitalization reaches 29% versus 17%, which were treated in 12 hours. Now, we're going to treat people before 12 hours, but just goes to show how much better patients are when they get to the appropriate places they need to go, and having a troponin quickly will help facilitate that. In 2024 alone, there were 15 million presentations to the emergency department for chest pain in Europe and the United States. It accounts for approximately 1 to 10 attendances and 4 to 10 unscheduled admissions to the hospital. Chest pain and ACS, or more innocuous things that aren't life-threatening like angina, it's a heavy burden on the emergency department, and it causes overcrowding while we wait for results. And furthermore, not every patient presents with traditional ACS symptoms. So you can have a perfectly normal EKG. The patient could be having some kind of atypical symptoms. You think they're doing okay. You're waiting for this troponin. Meanwhile, the patient could be having a cardiac event, and we don't know. And I just wanted to kind of touch on the patients in particular that have atypical presentations of MI. Women. Women in ACS. According to the American Heart Association, 37% of women who are diagnosed with ACS did not present to the emergency department with chest pain. Saw this all the time as an ER nurse. Women often have atypical signs, and they're often honestly dismissed as anxiety or stress, or just missed completely by healthcare providers. So some of the big ones include vertigo, just sweating. Sometimes it's chalked up, especially for women over 50, to menopause. We've got vomiting, palpitations, syncope and near syncope is a big one I saw a lot with patients in the ER, and back pain and fatigue. And as women, we're always tired, so we just assume that it's just something that we usually deal with and it's nothing different. Unfortunately, MI is the leading cause of death for women in the United States, and what's more, women tend to have poorer outcomes than men if they do survive the MI. When considering the lack of typical symptoms and possible abnormal EKG that women may present with, rapid I-stat troponin could potentially diagnose women with ACS faster and improve outcomes. This is near and dear to my heart. My grandmother died of an MI when I was 10 years old. She did not have typical symptoms. She was dismissed, despite the fact that she was a diabetic, which is, it totally increases our risk for heart attack as women. I unfortunately watched her go into cardiac arrest, and I watched her resuscitation. It was very traumatic. However, it also made me want to be an ER nurse. So there's that. So what do we have here? Considering the previous slides and what we know about the outcomes for patients that do not receive prompt treatment for ACS, care pathways that accelerate diagnosis and allow for alternative settings for assessment outside an emergency department environment are clinical priority. There have been discussion about the use of I-stat machines by first responders in the field as well. Clinicians say, a paramedic can give an EKG, they can give nitro, they can do all these life-saving interventions in the field. What if we could figure out what their troponin is in the field? And then instead of sending them to a poorly equipped hospital for any cardiac emergency like the one I worked with, let's just send them right to the hospital that we know has a cath lab. Let's just bypass and get to where we need to be. This better prepares the emergency department and our teams too. Say they're 5 minutes away, and going to the cath lab is not going to make sense. They need treatment now. At least if we know, as the providers in the emergency department, we can prepare, call the cath lab, and let them know, hey, we're going to have an emergent transfer quickly. And in this picture right here, that's actually not the troponin, but it's a flight nurse. They're in the air. That's for PTINR. But just to give you an idea of knowing what's happening in the field can be such a big help. So what's the cost analysis, the I-stat troponin testing? Now, it does need regular maintenance, calibration, performance testing, and all those things. In addition, the nurses and staff in the ER need to learn how to operate the machine. But again, it's very easy to use. If you can draw blood, or check a blood sugar, you can use an I-stat. Also, there needs to be successful integration of point-of-care testing that connects to the lab as well as the EMR rather. That can seamlessly integrate into Cerner or Epic. My company, I work for Atlanticare, they as soon as you dock the I-stat, it started to connect to the system to try to upload the results, very similar to the glucometer. And here's the I-stat at bedside. You see the EKG, you see the doctor there. I'm assuming a doctor could be a nurse practitioner or a PA. And so despite the cost when used in conjunction with the traditional laboratory troponin, POC troponin testing assay was a statistically equal assay in terms of diagnostic accuracy for MI. The improved clinical sensitivity of the PCO troponin suggests that a product is now a viable option. And then furthermore, according to statistical analysis, the PO tests have a strong correlation with laboratory results. So it's accurate, and it also can help us identify, well, it identifies the signs of heart damage, and it can ensure that the results are reliable without missing any 30-day MACE incidents. So MACE is major adverse cardiac events following MI. There's a lot of patients that come back after they're discharged from the hospital with acute chest pain or diaphoresis. So if we can figure out right away that this person, their troponin is still pretty high, it didn't come back down from before they were discharged, all right, we need to either readmit them or, hey, everything looks good, maybe this is just anxiety, let's call the cardiologist and see what they would like to do. And this can really help with healthcare costs, because readmissions for MACEs is a massive healthcare resource and utilization costs. And in the United States alone, it costs about $4.6 million a year. So if we can prevent patients from having to come in again after an MI, the hospitals are going to want to do that. As we talked about in the previous slide, troponin is very accurate. There's a large cohort of patients with possible ACS in a recent study. In 28 EDs, and the POCI stat had high sensitivity and negative predictive value for early detection of acute MI. It also has a low negative false rate and a high correlation, again, with the laboratory automated additional blood tests. There's a cartridge on the right there. iStat troponin is one of the first POC options for measurement of troponin with equivalent clinical sensitivity. And again, it can be a viable, cost-effective, and accurate tool that should continue to be used in emergency departments worldwide. And now the professional opinions on iStat troponin. Having used this many times in my career for many years, I can tell you it's fantastic. I worked for 2 major health institutions, in this 3, but in the emergency department I worked for Atlantic Care and for Inspira. Inspira does not have troponins, and when I worked in the small rural ER, I mean, you could be waiting on a busy day in the ER, hour and a half. You're constantly calling the lab. When's the trope done? When's the trope done? If you have it right at bedside, 10 minutes, and you have an accurate reading on if the trope is elevated or not. I did find it to be a little temperamental. The cartridge, it needs to be placed very gingerly into the little slot at the bottom. Sometimes it'll reject it. Sometimes they go through 5-10 minutes of just maybe like checks and calibration just to have it spit out and tell you, no, you need to do another sample. So that is a little frustrating sometimes, but it didn't happen all the time. And if you take your time and really get the blood on the sample properly, this generally tends not to happen. Now, what I read when I was doing research on this, the temperamental nature of the iStat is probably due to the fact that iStat automatically runs a comprehensive set of quality checks of both the analyzer and the cartridge. And although this is somewhat annoying, it's actually a good thing because it can ensure the quality of the testing. And again, we just need to be very careful. Get the dropper. I think it's like 3 drops or 1 drop it needs. I can't remember exactly how many drops, but just take your time, and typically you won't get the errors. And then, like I said, however, these checks and controls only lend itself to the validity and efficacy of the iStat machine. ER docs love it. Every ER doc that I loved it. They loved being able to call an interventionalist and say, hey, I got a couple ST segment elevations here. I got a bundle branch block. I got, a second degree block. And hey, Ash, what was the troponin? Did it result? Oh, I got a troponin of whatever the institution's troponins are. Every place kind of uses a different value set. They love the fact that it can improve clinical output times. It can, let's say you get a 20-year-old with chest pain and has no heart score whatsoever. They never drank, they never smoked, they haven't been on a long flight, none of those things. And they have EKG's normal, chest X-rays normal, and you're just waiting for a quick troponin to come back so you can discharge them. If the troponin's negative, we're discharging them. They're going home. Throughput times are improved. And then they are a little hesitant to use this for patients with things that can up a heart score, like diabetes or smoking or coronary artery disease. They're still going to wait for the traditional results, especially for an NSTEMI, but it gives us an idea of what it's probably going to be. Cardiologist opinions. Cardiologists pretty much are the same as emergency departments. The opinion, It's good for low-risk patients with low heart scores, but they still want the traditional serial troponin testing, and we do one at 1 hour, 3 hours, and etc. So they still want that gold standard laboratory test. My final thoughts, based on the evidence, studies, and professional opinions I have researched, the iStat troponin is a highly efficacious, reliable, cost-effective, and rapid tool that can be used to triage and initially evaluate ACS. When used in conjunction with traditional laboratory troponin testing, it can accurately and quickly determine ACS, improve outcomes, and increase overall morbidity and mortality. Here are my sources, and thank you so much for listening to my presentation.